Next, I'm going to cover surgery, radical prostatectomy, as a means of curing prostate cancer. As a reminder, if you are skipping ahead to this section, the QR code down in the right here will take you to our webpage with updated to-the-minute information. So what is prostatectomy? So radical prostatectomy means removing the entire prostate gland along with the seminal vesicles, which are the glands right next to the prostate, which together with the prostate make the fluid that surrounds sperm and comes out with ejaculation. The part of the urethra, the tube that drains the bladder toward the penis, the part of the urethra that goes right through the middle of the prostate is removed together with the prostate. The bladder is sewn down to the urethra here to meet the sphincter muscle, which sits right under the prostate here. In some cases, in cases of higher risk disease, we will also do a lymph node dissection and remove the nodes along the pelvic bones, which are the nodes where the prostate cancer cells are most likely to go if they're going to escape the prostate. Traditionally, prostatectomy was done through an open incision above the pubic bone. Today, the vast majority of these procedures at UCSF and at most other major centers are done in what's called a robot-assisted procedure. This is not really a robot. Robot implies autonomy. The Da Vinci machine, which is the machine that we use, allows us to translate the surgeon's motions inside the body using 3D visualization and incredibly good fidelity of translating my right hand to the right hand of the instrument during the surgery. We do this through 5 or sometimes 6 small incisions across the upper abdomen. We fill up the belly with carbon dioxide gas, and we're looking down toward the prostate while we do the surgery. Now, it's critical to stress that the most important thing here is the skill and experience of the surgeon, not the machine. If you have a surgeon who's done 2,000 open operations with good results, he or she should just continue. You would much rather be open operation number 2002 than robot operation number 2. For that surgeon. And every surgeon really needs to know his or her own outcomes, and you should ask questions about surgeons' individual outcomes, because again, the skill and experience factors far outweigh the methodology or the approach in terms of open versus laparoscopic versus robotic. So what's involved? Whether we do this open or robot-assisted prostatectomy requires general anesthesia. Short-term risks of the surgery are really quite low. Risk of bleeding to the point of needing a transfusion is only about 1%. The infection risk is pretty minimal. We typically give an antibiotic to minimize that. For somebody that has not had a lot of prior belly surgeries or prior radiation to the prostate, the risk of injuring organs around the prostate, such as the rectum or the small bowel, really should be no more than theoretical. Most men stay in the hospital 1 night after the surgery. There are centers which are doing this as an outpatient procedure. We typically don't hear because many men that have surgery here are coming from hours away. So most men will spend 1 night in the hospital. We leave a catheter called a Foley catheter, which drains the bladder for 1 week after the surgery. It drains the urine to a bag you wear on your leg. The catheter is a nuisance. It is not painful. And we typically recommend avoiding any sort of heavy lifting or strenuous activity for 4 to 6 weeks, just to avoid a hernia forming through one of the incisions. But we want lots of walking. You're on your feet literally the day of the surgery, up and down the halls the next day before going home. And the overall recovery is typically pretty straightforward. Most men do not need much in the way of pain medication beyond Tylenol and ibuprofen, although we do give some a handful of narcotic pills to take home in case you need them. So 2 minor advantages with the surgery. Number 1 is that when we take the prostate out, we get the final word on the grade and the stage, because the whole prostate goes to the pathologists and they will tell us the final grade, final stage. We get this within 2 weeks after the surgery. If there's questions about the margins during the surgery, we can send what's called a frozen section, which is a preliminary look at the margin, but we really do wait for this final pathology report. And then within 2 months after the surgery, the PSA should fall to undetectable. We can't quite say 0, but a very low level below some threshold. Typically here, it's 0.015 within about 8 weeks after the surgery, and it should stay undetectable forever. If it rises in the future, we worry this might be indicative of recurrent cancer. And at this point, we can repeat imaging, typically at this point with a PSMA PET when the PSA gets to around 0.2, and talk about additional treatments such as postoperative radiation therapy. Now, long-term, what really matters is to cure the cancer, maintain urinary function, and maintain sexual function, usually more or less in that order. So again, cancer control, as I just talked about, we assess with the pathology report and most importantly with the PSA outcomes. And the likelihood of curing the cancer is really driven by the disease risk. We're much more likely to cure a sort of low intermediate risk cancer than we are to cure a very high risk cancer outright. So what about urinary recovery? Well, when we take the catheter out of the bladder, that's typically 1 week after the surgery, most men will have a degree of incontinence or urinary leakage, especially with things that tense up the belly muscles like cough, strain, sneeze, stand up, laugh. Again, anything that tenses the abdominal muscles will tend to cause leakage. We are usually talking about a few drops with sneezing, not an open water faucet. So typically men will manage this with urinary pads, which are kind of like women's menstrual liners. We're not usually talking diapers. The duration that you need to wear the pads can be variable. This depends on age, on the size of the prostate, on some technical factors during the surgery, and also on just the native length of the urethra and some anatomic factors, which are beyond anyone's control. So the duration is a little bit variable. Some men get their continence back quite quickly within the first couple of weeks. The average time is 2 to 3 months, but it can go on for up to a year before we say this is how life is going to be. By 1 year, in our hands at UCSF, likelihood of good recovery is about 90% of men who are able to get rid of the pads, or even a little bit higher than that. Of the remainder, 6 to 8% of men will have minor long-term leakage where you wear 1 pad a day long-term for a couple drops of the leak with sneezing, etc. Likelihood of bad leakage past a year, where we're talking about multiple pads a day, diaper scenario, that is pretty uncommon in our hands, no more than about 1%. And it's really important to stress that there are things we can do to address incontinence when it does persist past a year. We see all the time men who are years out from treatment, often treated elsewhere, who are having pretty severe incontinence, which could have been addressed. There are things like sling procedures, artificial urinary sphincter procedures, which really can address leakage, if not perfectly, to a great extent. So there should be no suffering in silence once we get past this 1 year point after the surgery. Now, it's also important to note that BPH, benign growth of the prostate, very, very frequently coexists with surgery. And one other advantage with the surgery is by removing the prostate, we remove any degree of obstruction. So if you have a lot of obstructive symptoms just from having a big prostate, in addition to the prostate cancer, while this is a bit of a killing 2 birds with 1 stone situation, and by de-obstructing the prostate, we will actually often improve urinary flow substantially. So for men that have obstruction going in, it's not uncommon to actually wind up with better overall urinary function 6 months down the road than where you started. Now, what about erectile recovery? So the nerves that drive penile erections run all the way from the bottom of the spine, all the way along the pelvis, along the prostate on the way to the penis. The nerves are not actually really involved with the prostate directly. It's just that they run stuck to the prostate. So they're a bit of a bystander when we take the prostate out. And even when we spare these nerves, they do get stretched, they get heated up. There are microscopic nerve fibers on each side, and they're quite sensitive. So even when we do spare nerves, they're going to shut down from the point of the prostate forward and then have to recover all the way from the spine. And this takes time. Now, how much we can nerve spare depends on clinical factors like the grade of the cancer and critically on the imaging. So if the cancer is high grade, but we have pretty good confidence it is not past the edge of the prostate, we can still spare most or all of the nerve. And typically we will spare all the nerve on the side where we don't have high grade cancer. Now, as I said, even with good nerve sparing, erections will still take a hit after the surgery. In fact, they may often get worse for the first 2 months after the surgery, and then you get recovery over time. Now, this recovery can be, and usually is, much slower than the urinary recovery. It can take 2 years or even longer for sexual function to get back to where it's going to be. In our hands, if we do bilateral nerve preservation, about 2/3 of men will get back to baseline function by 2 years after the surgery. But this is very variable depending on how much nerve sparing we can do and based on what baseline function is. Unlike the urinary piece, we never make anybody's sexual function better in any way by doing surgery or radiation or any other treatment to the prostate. Now, we're aggressive as a man wants to be, with so-called penile rehabilitation. So even though we can see a 2 year recovery period, we don't wait that long. We get aggressive with medications like Viagra and Cialis pretty early. If these are not sufficient in the first couple of months to get at least partial erections going, we get more aggressive with things like a vacuum device, injection therapy. There's a whole range of things we can do to force the issue and get blood flowing. Now, even if we do get good erections back, even if they come back quickly, there's no ejaculation ever again. The seminal fluid, as I said at the beginning of this section, is made by the prostate and seminal vesicles. So after surgery, you can still have an orgasm, which is in the brain. You still feel muscle contraction, but there's a so-called dry climax. And for this reason, too, fertility is not possible. You literally get a vasectomy as part of the surgery. If fertility may be a concern, you can bank sperm in advance of the procedure, or it is possible to harvest sperm directly from the testis down the road, but that does mean an additional invasive procedure. About 5% of men notice a slight shortening of the penis after the surgery. This is typically a concern for men who carry a lot of fat in front of the pubic bone and those who have a very large prostate where we have a large gap to bridge. This is typically temporary, and I would say it's only about 5% of men that notice this. It's usually about a half an inch when it is noticed, and it usually gets better with time. Now, some of these side effects may be worse if the surgery is combined with radiation therapy, especially if the radiation is given before surgery. So for men who get radiation after surgery who have had a good urinary recovery, we usually see stable urinary function. If they're still having leakage at the time of the radiation can fix that recovery in place. So it can be harder to get to completely dry if there is still leakage at the time of the radiation. Now, on the other hand, if you've had radiation first and are getting surgery as a so-called salvage procedure after radiation, then all these risks are substantially higher. The risk of rectal injury, for example, becomes a real possibility. The risk of severe incontinence is more like 1 in 4 rather than 1%. These can still be dealt with, but the risks are substantially higher. For more details specifically on prostatectomy, you can see this link here or the QR code, and there's a video by one of our nurse practitioners who talks in a lot of detail about what's involved in preparing for surgery and handling the perioperative period.